Let's spend some time now and talk about the vaccine. Again, you cannot have an eradication goal without having an effective or efficacious intervention, in this case, a vaccine. So let's talk about the vaccine in polio. So earlier on, like we discussed, polio was an epidemic disease. So it was occurring in the US at specific months, usually in the summer months when children, are more exposed to the environment. And you have the scenario where it will come up at specific seasons, and you'll have children come down with the disease and some come down with paralysis. And there was a lot of attention to this because it was really scary. People really didn't understand the disease, and there was a lot of interest in developing a measure, a vaccine to address this disease. So there are two major types of vaccine that were developed. The Salk vaccine, which was developed in the late 1940s/early 1950s, which is really using a killed version of the virus, that is to say, version that cannot cause any infection, to elicit development of antibodies within the host, prevent infection with white polio virus. So that was really the first vaccine for polio that was developed by Jonas Salk. And this is delivered using an injection, a needle. And then much later on in 1963, an oral version of the vaccine was developed. Unlike the Salk vaccine, the oral version of the vaccine really contained the live virus, but attenuated. That is to say that some part of the virus has been knocked off in a way that it's no longer virulent. So some particular basis within the virus has been changed so that it doesn't cause any virulent infection when it is administered. So, but at the same time, it still retains the ability to elicit production of immune properties and antibodies to fight infection. So that was the oral polio virus. So we have these two vaccines. One, the injectable vaccine, which is based on the killed virus, and then the oral polio virus, which is live virus, but it's attenuated. It was thought to have very reduced ability to harm the recipient of the vaccine. In the picture, you see, still talking about the Sabin virus, you see the famous Red Sox team really illustrating the usefulness of the oral polio vaccine for polio prevention. So this is really helpful for communication and for educating population about the safety of the vaccine, the need for individuals to receive the vaccine, and so on. And then in the second picture, you see people lining up to receive vaccination. Such was the interest and the desire within the population to receive this vaccine. So again, it really describes how it was important in the early 60s to address polio, and how people recognize that vaccine, particularly oral polio vaccine, since this was readily available, it doesn't require an injection, was a major vehicle for achieving mass immunization and reducing the epidemic of polio virus in the United States. Now, a disease is epidemic proportion. That is to say that it occurs at a particular period, and the incidence rate is noticeable over that period. It's easier to communicate effectively to the population of a need to use vaccines. So everybody can see the disease spreading rapidly over a period of time. You see an increased number of cases, rapid increase in the number of cases over a period of time. So these are all characteristics of an epidemic disease, which was the way the poliomyelitis was viewed back in the early 60s and in the late and in the 50s, when there was a lot of interest in using the vaccine. That outlook or that perspective is different from the endemic perspective. In a scenario where, the disease is almost naturally occurring in the population, and you really don't, the characteristics of is continually transmitting within the population. It doesn't have like a specific season or a specific time when the disease transmits. So this has implication. So communicating about the need for vaccine for an epidemic disease is different from the way that you communicate the need for vaccine for an endemic disease. So we know that the epidemic nature of the polio in the United States in the 50s meant that it was a sort of fear and dread for mothers. So it was easier to communicate the use of the vaccine, either the injectable vaccine or the oral polio vaccine within that scenario. But in most places where the Global Polio Eradication Initiative is working, mostly in low-income setting, the disease is endemic. And this is to say that it's occurring throughout the year. There is no pattern of, there's no epidemic pattern in which it clusters around a particular period, and this has implication because the way to communicate the need for the vaccine is really peculiar in such setting because there's a lot of need to do it on a continuous basis. There's a lot of need to repeat vaccination and so on. And therefore, there are strategies that the Global Polio Eradication had to develop or evolve over time in order to overcome these challenges of maintaining interest in the vaccination at the global level and at the country level and within population where the disease are endemic over a protracted period of time. So I would just like you to take a moment and think again about what are some of the implications for polio communications and immunization when you're thinking about a disease that is endemic, that is to say a disease that is year-round within a community versus a disease that is epidemic that occurs at a time-limited period where you have a rapid increase in number of cases. What are the implications of polio presenting or manifesting as an epidemic disease in one setting and manifesting as an endemic disease in another setting? So what are the implications for how you communicate the strategy, how you communicate the vaccine, the need for the vaccine, and how you do mass immunization within each of those settings? So just take a moment and reflect on this and discuss with small groups if you have any small group that is listening with you, discuss. And then here, I would like you to also go pause this presentation at this point and then go and watch the story about the polio vaccines. And let's think about what are the different advantages, the disadvantages of the injectable vaccine, which was first discovered, and the oral polio vaccine, which was later discovered with respect to addressing epidemics of polio, addressing endemic transmission, and some of the challenges with the properties of the vaccines, and so on. So take a pause now and go watch the video. So what are the advantages of having the oral polio vaccine, the OPV, which we described earlier on as having a live but attenuated version of the vaccine? So one major advantage is that it's really inexpensive. It's less than 20 cents for a dose, and it doesn't require any trained staff to administer. Anybody can administer it. It's just to put a drop in the mouth, and that's it. And again, because it's excreted into the environment. So remember when we talked about the way polio virus replicates in the human body, it's really shared from the gastrointestinal tract and it's excreted into the environment. And then as it's circulating in the environment, people who were not even vaccinated are exposed to this circulating virus, and they actually it elicits a generation of immune properties in those unimmunized individuals. So they're able to develop antibodies to the white polio virus as a result of exposure to excretion of the live attenuated virus that was excreted by individuals that were immunized. So this confers what we call an herd immunity. So you have the benefit of the vaccination that extend beyond the people that were directly immunized. So you have other people that were secondarily immunized as a result of exposure to the virus shedding or the vaccine shedding from the individuals that were immunized. So these are some of the relative advantages. And what these advantages translate to is that it actually allows for massive, rapid deployment. So if you don't need trained health workers to deliver the vaccine, you can readily immunize large population with the oral polio virus. You can go door to door, house to house. You don't need any special technique, and you can achieve herd immunity quickly with the polio virus. So this made it very attractive for mass immunization campaign, particularly in low and middle income country setting. And it has been the major strategy for the Global Polio Eradication Initiative in recent times. But of course, it also has some disadvantages. So even though the vaccine is relatively inexpensive, we also know that it has a lower dose efficacy than the injectable vaccine in many contexts. So that is to say that the ability, the extent to which the vaccine is able to produce, elicit production of immune properties in the individual, it's lower compared to the injectable. So therefore, you need more doses of the oral polio vaccine in order to achieve immunity in an individual. And then again, even though the vaccine, the live vaccine in the oral polio vaccine, the live virus in the oral polio vaccine has been attenuated, that is to say, it has been changed in a way that it's less likely to lead to an infection of virulence within the individual. We know that in rare cases, there's what we call vaccine-associated paralytic poliomyelitis, which can occur when, over the course of replication, the virus in the vaccine can regain its virulence factor. That is, it can regain its ability to cause harm, to cause paralysis in an individual. And this is really significant because in recent times, we've found out that these change viruses within the vaccine can continue to circulate in the environment, right? And over the course of circulation in the environment, it can continue to gain more virulence and capable of causing paralysis. And this has been sometimes called the circulating vaccine-derived polioviruses. So the oral poliovirus in of itself, as it is, in very rare cases can cause paralysis in some individuals, particularly individuals who are immunocompromised, individuals who, for some reason, who have very low immunity. And in other cases, it can change. The virus in the vaccine can change in the intestine and can be shared into the environment, and that circulating virus can again cause paralysis within the human population. So again, a major challenge that the Global Polio Eradication Initiative faces right now is as a result of some of these disadvantages. So we have instances right now where we have more cases of circulating vaccine-derived polioviruses, which are as a result of use of the oral polio vaccine occurring all over the world, even much more than the wide infection due to the wide poliovirus. And then for the injectable polio vaccine, which contains the killed virus, the major advantages is that there is no risk of vaccine-associated paralytic polio. So that is to say the vaccine in of itself cannot cause paralysis. Right? We said that the OPV, the vaccine administered to an individual can cause, there's a risk of paralysis in the individual that receives the vaccine. And there is also the risk of a modification to the virus in the vaccine in the intestine of the individual, which is shared into the environment, which can circulate in the environment and cause the circulating vaccine-derived polioviruses that is seen among human population. All of these does not exist with the injectable polio vaccine. And again, it produces more effective immunity in individuals. So it doesn't require the amount of the per dose efficacy for the injectable polio vaccine is actually higher than the oral polio vaccine. But the disadvantage is the cost. So it's really expensive relative to the OPV. And there are limited capacity to really produce it rapidly on scale, unlike the OPV. And then again, it also requires it to be administered by a trained health worker. So there is an additional cost that is required in terms of making sure that you have a trained health worker delivering it. Just not anybody can deliver it, unlike the OPV. So, and that's why it's less suitable for mass immunization, particularly in resource-poor setting and low-income setting, where we have the white polioviruses still being endemic. And then you require other supplies, other consumables like sterile needles to administer it. And then again, some parents are just very hesitant to injection. I mean, it's a different ballgame when you put something in the mouth as compared to when you actually inject. And in some cases, we know that injection in of itself has been associated with increasing the risk of paralysis for people who have been previously exposed to the white poliovirus. So again, these are some of the disadvantages. But to be clear, you would see that both of these vaccines have their role and their relevance in an eradication initiative. So for instance, we know that the injectable really was credited for actually helping the United States to eliminate the epidemics of polioviruses rapidly. Much later, the oral polio vaccine came on board. But in low and middle income country setting, the OPV has really been very helpful in rapidly scaling up mass immunization across different contexts and different settings. But now we are seeing challenges with the circulating vaccine-derived polio viruses, which is as a complication of the oral polio virus. So again, and there may be a need for use of the injectable polio vaccine, which is what is underway in a lot of low and middle income country settings. So you really do need both in order to achieve the eradication goal. Because you have 3 different strains of white polio viruses, you have type 1, you have type 2, and you have type 3, the vaccine are produced in a way that they can address each of these strains. So you have the monovalent vaccine, which targets a single strain of the white polio virus. So you could have a monovalent or oral polio vaccine type 1, or monovalent oral polio vaccine type 2, or monovalent oral polio vaccine type 3. And then you could also have bivalent, which really can actually vaccine that can address 2 strains of the white polio virus. And then you have the trivalent, which combines vaccine that can address the 3 different strains of the white polio virus. And we know that even as we speak, that efforts are underway to produce other types of vaccines that are more stable, particularly oral polio vaccines that are more stable with less likelihood of regaining virulence, so that they can be used to address the scourge of the circulating vaccine-derived polio viruses as a result of the use of the OPV, the oral polio vaccine.